Good evening, everyone. How are you all? All right. So tonight we are going to finish psychiatry. So this is the psychiatry third class. So I hope you guys have finished the first class that we have taken in our trial session. And then the last class, we did cover a lot of things which are important. And today we'll try our best to finish the rest of it. So the first topic that we are going to start today is personality disorder. Very important for exam. Let's start. So for personality disorder, we have cluster A, cluster B, and then we have cluster C. So different people are born with different personalities, and throughout their development, the social, environmental interactions change their personality into a single personality, right? So, and those personalities are the person's identity. So we divide these different kind of personalities, especially like some of the personality disorders, into three clusters. So cluster A is the withdrawn personality people, cluster B is antisocial, and cluster C is dependent. So for cluster A, the withdrawn personality, we have got paranoid personality disorder, we have got schizoid personality disorder, and we have got schizotypal. So paranoid personality disorder patients, they are suspicious of everything. Whereas schizoid personality disorder patient, they are like, they're cold and humorless. Schizotypal are kind of, you can say they are odd and eccentric. Now, there are a lot of things that we are going to discuss for all of them, but just to give you a generalized idea, cluster B, we have got antisocial, histrionic, narcissistic, and borderline. So these are very important for exam. And in cluster C, we have got avoidant, dependent, and obsessive compulsive personality disorder. Starting with the cluster A, paranoid personality. So as you can understand, paranoid means that they are suspicious and distrustful. So they don't trust anyone. They are suspicious of everyone's motivation, and they think that everyone is trying to harm them or everyone is spying on them. Like this patient, a 57-year-old man living in a condominium complex, constantly accuses his neighbors of plotting to avoid payment of their share of maintenance. He writes angry letters to other owners and has initiated several lawsuits. He lives alone, does not socialize. So these are withdrawn group who usually likes to just keep within themselves. They don't like to like mix with other people. They don't like to go out and meet others. So paranoid personality disorder means that they are suspicious and mistrustful for everything. That's the main thing. Whereas schizoid personality disorder, they have emotional restriction and they are emotionally very distant. They are disinterested in others and indifferent to praise or criticism. That means they don't actually like to meet with anyone. They don't have any interest in others, and they don't care whether you are criticizing them or praising them. Like this patient, a 24-year-old man lives alone, works nights as a security guard. He ignores invitation from co-workers to socialize and has no outside interest. So schizoid personality disorder patient will be like that. So they are emotionally distant and they actually choose not to socialize. Okay. How about schizotypal? Schizotypal are, you can think that they are very odd and eccentric. That means they have a very peculiar pattern of thinking. They have odd preoccupations, odd speech, and you can think that they think that they are fortune tellers. They think that they knows magic. They have interest in something very particular. Okay, so these are the patients who will dress oddly and they will have kind of like a unusual, weird behavior. Okay, so unlike schizoid personality, they have peculiar pattern of thinking, including sometimes they have like odd speech, odd preoccupation. That means they feel that they know they are powerful or they are supernatural, something like that. So like this, a 30-year-old man is completely preoccupied with the study and brewing of herbal teas. So they will be very interested in something very peculiar or particular. He associates many peculiar powers with such infusions and says that plants bring him extra luck. So you can understand the odd and eccentric thinking. He spends all of his time alone, often taking solitary walks in the wilderness for days, collecting plants for teas. He has no history of disorganized behavior. Now that rules out schizophrenia. At times, he believes that songs on the radio are about his life. So if someone thinks that like TV, newspaper, or songs are talking about them, that is what we call as thought broadcasting. So thought broadcasting, or if patient thinks that people are talking about him all the time, that's also known as idea of reference or delusion of reference. So this kind of patient can also have this behavior. Okay. So schizotypal personality disorder, they are odd and eccentric, they are fortune teller, they think they have some special power, and most importantly, they have a particular interest in something, and they usually do everything for that particular interest. Okay, so we have got paranoid personality who are suspicious. We have got schizoid who are emotionally distant, doesn't like to interact with others, and schizotypal who are odd and eccentric. Next, cluster B. Cluster B is, first of all, we have histrionic personality disorder. So histrionic personality disorder is common in female, usually characterized by colorful, exaggerated behavior and excitable, shallow expression of emotion, and they use their physical appearance to draw attention to self. They're sexually seductive, and they are not comfortable where they are not the center of attention. A 30-year-old woman presents to the doctor's office dressed in a sexually seductive manner and insists that the doctor comment on her appearance. When the doctor refuses to do so, she becomes upset. So histrionic personality disorder are the person who are sexually seductive and they want to be the center of attention. Okay. Next is borderline personality disorder. Now, borderline personality disorder is one of the most important ones out of anything that we are discussing now. So borderline is common in female, not very common in male. So borderline they have some specific diagnostic criteria. So they have unstable affect with frequent mood swings. So these patients will have frequent mood swings. Sometimes they are totally good. Sometimes they can have anger outburst. So inappropriate anger. They are very impulsive. That means they can go out and have like lots of drug abuse. So impulsive behavior is common. Very important is that because of their mood swings, relationship is a very difficult thing for them. So they have unstable relationship with frequent divorce or separation. And they also have frequent suicidal behavior. So they do self-harm, and sometimes even they want to suicide. If they are stressed, they can also become psychotic. They use a defense mechanism called splitting. So splitting is a defense mechanism these people use, and splitting means that they think that a, a particular thing or a person is either good or bad. There is nothing in the middle. So it's either good or bad. That's called splitting. So they split everything into half. So they either think that you are a good person or you are a very bad person. Okay. So that's borderline personality disorder. A 20-year-old nurse was recently admitted after reporting auditory hallucination, which have occurred during the last few days. She reports marriage difficulties, believes her husband is to blame for it. She has several scars on her wrist and history of substance abuse. So you can see impulsivity, self-harm, then also relationship problem. And when they're stressed, they can become psychotic. That's why the hallucination is here. So borderline personality disorder, because they have these suicidal thoughts or self-harming behavior, the best approach of treating this patient is called dialectical behavioral therapy. So dialectical behavioral therapy. So DBT is a particular CBT or cognitive behavioral therapy where the psychologist will mainly focus on reducing the self-harming behavior this patient has. Okay. So DBT is the treatment of choice for these patients. Dr. Umi, are they concerned about their behavior? No, they are not concerned. Withdrawn patients, they actually choose to be withdrawn. So they are not concerned. Histrionic versus ADHD. A lot of difference. It's a total different thing. So when we will discuss ADHD, you will understand. Antisocial personality disorder. So antisocial personality, as the name says, they are the rule breakers. So they are the person who has these continuous criminal acts. They don't actually abide by the social rules. And most importantly, they are aggressive, violent, and lack of remorse. So they will do something bad, but they will not feel any empathy for it. Now, to diagnose a person to be antisocial, the person needs to be at least 18 years of age. So before 18, you can't diagnose anyone as antisocial. So a 22-year-old man was recently arrested after he set his mother's house on fire. He has had numerous problems with the law, which started at an early age when he was sent to a juvenile detention center. He lacks remorse for setting the fire, expresses a desire that his mother would have died in the fire. So you can understand that antisocial is mainly patients who harms others and they don't actually have any guilty feeling for that. Easy, Dr. Midhat. So antisocial harms people. And schizoid personality disorder, they don't do anything. They don't even want to meet with any people. So they don't harm others. Okay, paranoid disorders means that, now remember, it is not disorder, it is a personality disorder. Someone who is having this paranoid personality, they will have this problem throughout their life. Whereas delusion will just start suddenly, like the delusional disorder. It will not be for the whole life. Delusional disorders means they have a false belief, whereas paranoid is only about suspicions about something. Okay, so the main purpose should be paranoid personality disorder is for a long time, especially for the whole life, patient will have this kind of symptoms. So you will get in the question that multiple times throughout his life he was like this, whereas delusional disorder might be just very recent belief. Okay. And the same thing, paranoid personality disorder, it will affect their social personal life, whereas delusional disorder, it will not affect their personal or social life. So difference between schizophrenia and schizoid. So try to understand what is schizoid and what is schizophrenia, then you can easily differentiate between these. Schizoid is patient who doesn't have hallucination, doesn't have delusion, doesn't have disorganized behavior. So if they don't have any of those, how can it be schizophrenia, right? So the thing is that the basics should be strong to be able to differentiate between these things. Okay, so once you understand how I can diagnose a patient as schizophrenia, then you can also differentiate between everything. Okay. Next is narcissistic personality disorder. Narcissistic personality means that, so narcissism is common in male, antisocial is common in male. Okay. So narcissistic personality, they are egotic. They always have this kind of like a sense of self-importance. They feel that they are the only person who is the boss of everything. So they have grandiosity. They believe that they are very special and they require excessive admiration. If you criticize, they will react with anger outburst. They will raise. They lack empathy. They are envious or jealous of others, and they are like exploitative. So they are manipulative, exploitative. They do everything just for their own gain. Okay. So egotic patient, self, like who only thinks about self-importance, requires a lot of admiration, they will be the narcissistic. A famous actor is outraged when a director questions his acting abilities during rehearsal of a play. The actor responds by walking off the stage and not returning to the stage unless the director apologizes publicly for her behavior. So you can understand the egotic behavior. So that's narcissism. Does it make sense to everyone? Like how to differentiate histrionic, borderline, antisocial, and narcissistic? Okay, moving on. Cluster C. Cluster C is the dependent personality. So we have avoidant personality disorder. So avoidant personality, they want to meet with others. Okay, so they are not like the withdrawn personality that they don't like. So avoidant personality, they want to, but they have like fear of rejection. They have feeling of inadequacy, low self-esteem. So individuals have social inhibition, feeling of inadequacy, and hypersensitivity to criticism. They shy away from work or social relationship because of fear of rejection. They feel lonely, substandard, and preoccupied with rejection. So the main part of avoidant personality is that they want to socialize, but they avoid going to the social gatherings because of fear of criticism. Okay? A 43-year-old man dreads an upcoming company holiday party because he believes that he's incapable of engaging in social conversation or dancing. He believes that he will become an object of pity or ridicule if he attempts such things. He anticipates yet another lonely holiday. Okay, so you can understand. Then dependent personality disorder. So dependent personality are like whatever you do, whatever you say on their face, they will always be like they will always depend on you. Okay, and they always want the need to be taken care of. Okay, so individuals are consumed with the need to be taken care of. They are clingy. They don't like to be abandoned. They feel inadequate and helpless. And whatever you say, they will not go for any disagreement. Okay, a 26-year-old man is brought into the ED after sustaining severe rectal laceration during a sadistic sexual episode with his partner. The patient is extremely concerned that the police not to be informed because he doesn't want to upset his partner and cause the partner to leave. So you can understand, even though he is suffering, he doesn't want anything to be done for that. So that's dependent personality disorder. Next is obsessive compulsive personality disorder. Individuals who has this kind of personality, you remember obsessive compulsive disorder, remember OCD and OCPD is not same. OCD can be just like patient will have the obsession and compulsion, but when it is OCPD, it is something that has been there for the whole life. Whole life patient is like this. So individuals are preoccupied with orderliness, perfectionism, and control. They are consumed by the details of everything. They're strict, perfectionist. They're inflexible. Okay? So that means that they want everything to be in the right place. They want everything perfect. So that is when we call it obsessive compulsive personality disorder. So a 37-year-old woman seeks psychotherapy as a result of an impending divorce. She states that her demands to keep the house spotless, to maintain an extremely detailed and fixed work and recreational schedule, and to observe rigid dietary habit have driven her spouse away. Okay, so you understand what is obsessive compulsive personality disorder. So these are the avoidant disorders, or these are the cluster C people: avoidant, then dependent, and OCPD. In here, in the med bullets, you can also get to learn some of this personality disorder, and they have some other examples which you should go through. Okay. All right, moving on. So this is all about personality disorder, very, very important for your exam. Now, we are talking about gender dysphoria. So there are some gender disorder that comes in exam. So gender dysphoria is a condition or where patient actually have a persistent discomfort and a sense of inappropriateness regarding the patient's assigned sex. So gender dysphoric disorder or gender identity disorder It's a disorder characterized by a persistent discomfort and a sense of inappropriateness regarding the patient's assigned sex. So what happens in these patients is that they feel that even though they are male, they feel that they should be female. So they have a like a persistent discomfort about their gender. So that is what we call as gender identity disorder or gender dysphoric disorder. Now, gender dysphoric disorder also has few other things that you can go through. Let's see if we can open this up. Just a second. Okay, so in here, they have got few other things that you can go through. So you have got gender incongruence. So it's a marked, persistent experience of incompatibility between a person's gender identity and the gender expected based on sex at birth. Now, that it is the same thing. So gender incongruence is that when a patient feels that their assigned sex or gender is wrong. Gender dysphoria is when a patient has gender incongruence, experience significant distress or functional impairment because of this feeling. Okay, so gender incongruence is that they have that feeling, but it's not marked psychological distress. But when a patient who has gender incongruence, that discomfort feeling, and it's causing a significant psychological distress that affects their daily life, that's the time we call it gender dysphoria. So you can also have a look at what is cisgender, transgender, gender non-conforming, gender non-binary. So there are lots of terms nowadays that we use, not super important, but definitely just like it's worth to give it a read. Now, apart from this, in here, we also want you to know a little bit more about what is transvestism and what is transsexualism. So transvestism is a type of gender identity problem. So in transvestism, a patient will like to dress in opposite sex clothing, and they might also get sexual gratification for that. So when a patient likes to put on opposite sex clothes, and they might also get a sexual gratification just by doing that, that's what we call as transvestism. Remember, transvestism patient, they don't feel like they should be of opposite sex. That means a male gets sexual gratification by wearing women's clothes. But this male doesn't believe that he should be female. Okay? So that's the difference between transvestism and gender identity disorder. Because gender identity, the male will feel he should be a female. The other term is transsexualism. Transsexualism is a type of gender disorder where patient has that kind like severe discomfort about their assigned sex that they change their sex by some gender changing surgery or some other medication. So when a patient who has significant discomfort about their own gender or sex and they change their sex, that's what we call as transsexualism. Make sense, guys? That's right, Dr. Urmi. All right, so please go through this guideline from just write gender disorder or gender identity disorder. And we normally ask you to go through the Marks manuals or MSD manuals. Okay, so if you write it, it should come into the Google. Yeah, you can say that it is a severe form of dysphoria. Now, there is a chapter in John Murtagh about illicit drug overdose or illicit drug use. I normally don't discuss that in the class because it's all about just reading by yourself. So for illicit drug overuse, which will include smoking, alcohol, and some other illicit drugs such as cannabis, marijuana, heroin, okay, the ecstasy. So all the things that patient can, all the substance abuse will come into this. So substance abuse, there is a chapter in John Murtagh. I will show you that. That one you need to go through. And you also need to go through this link from RACGP about the illicit drug use. If we have some time at the end of today's class, I will show you a little bit, but otherwise, definitely you need to go through this, okay? Just give me a minute. I will share the John Murtagh with you, where you can get that substance abuse disorder. So if you open this one, so chapter 12 is drug and alcohol problems. In drug and alcohol problems, the important thing you should go through is smoking. So basically from smoking, you need to know that what are the treatments. So we have pharmacological treatment, which is nicotine replacement therapy. Then we have got other agents like bupropion, Champix, which is varenicline, and nortriptyline. So these are the common ones that we use for patients who wants to stop smoking. And this is important just to know, just give it a read, okay? You don't need to memorize anything, just give it a read. For alcohol, again, we do these case questionnaires for patients who are a problem drinker. And this case questionnaire sometimes comes in exam. Among these 4 questionnaires, this is the most important question that indicate patient is actually having a severe alcohol addiction. So if a patient says that they need to drink alcohol first thing in the morning to steady their nerve, that means that patient is highly addictive of alcohol. Okay, so you can go through some of the laboratory tests that we do in alcoholic patients. And what is the approach to management? So for managing a patient who has this kind of alcohol problem, there is a 6-step plan which you can go through this. Now remember, nowadays, the standard drink a patient can have is no more than 12 standard drinks a week. And for men and for women, no more than 8 standard drinks per week. It is best for pregnant women not to drink at all. So this is the standard drink patient can have now, okay? So there is a term called delirium tremens. So suddenly if a patient who is drinking for a long time and stop drinking, they can get withdrawal symptom. And the worst withdrawal symptom for alcohol is this delirium tremens, and it can be life-threatening. So patient after 1 to 5 days after withdrawal, if they start to get confused, disoriented, they're having tremor, visual hallucination, high fever, you think of delirium tremens. Okay, delirium means patient is confused and tremens is the tremor. So what would you do? So the first thing you do, hospitalize the patient, start the patient with IV fluid because they can be very dehydrated. And then you can give them thiamine, which is the vitamin B1, and then diazepam. Okay, so this is the main thing that you would order. These alcoholic patients can be deficient of magnesium. So very important is to check their magnesium level because many alcoholic patients are deficient of magnesium. And if they are deficient, you need to give them supplement. Okay, so IV fluid, thiamine, which is B1, and then diazepam. From the other substance abuse disorder, this is the table that you really need to go through. So this table has combination of all the illicit drug. The questions that come in exam that they usually give you a patient who has, and they give some of the symptoms of intoxication or substance abuse. And they can ask you that what is the most likely substance this patient is using. That's one type of question. And other question that they can already say that patient is overusing, let's say, amphetamines, and they can ask that what is the most important complication or what is the worst thing that can happen. Like amphetamine, patient can have hypertension, they can even have cardiac arrest. So that is one of the most important complication for amphetamine overuse. Okay, and you need to know that what are the physical symptoms this patient can have. So you just need to memorize this. There is no better way to know. Stacy, the same, it is amphetamine. You need to know about marijuana. So marijuana causes like initial euphoria. They can have this enlarged pupil. They can have craving of sweets. So those are the important feature. Now, this kind of patients, especially for cannabis or marijuana patient, they can have cognitive defect and they can have schizophrenia. Okay, so that's for cannabis or marijuana. As part of narcotics, opioid and cocaine is important to remember. Like patient who takes opioid like heroin, you might be able to find out that they have constricted pupils, which is very important finding. And this kind of patient can have respiratory depression, and that can cause death. So that's basically what comes in exam. So heroin, cocaine, then marijuana or cannabis, Stacy or any other amphetamines. Okay, so you just need to know what are the physical symptoms of taking this substance and what are the dangers. So what to do if a patient has opioid dependence? So opioid dependence is not uncommon. So for patients who has opioid dependence, a lot of complications can happen, which you can go through. So management is very complex for this group of patients, but there are a few things that we can do. One is that we can give buprenorphine. So buprenorphine can be done, especially if a patient is having like already having a withdrawal symptom. So if a patient has withdrawal symptom because of opioid, then buprenorphine is the treatment. But as a long-term maintenance treatment for opioid dependent patient, the best is methadone. So patient will take methadone and gradually the patient should be able to get out of this opioid dependence. And apart from methadone, we have buprenorphine and naltrexone as well. Okay, so you just need to remember the name of this medication that we can use for opioid dependent patient. Give it a read from cannabis from here, please. And that's all that you really need to go through. So my recommendation, because these are not something super important, but time to time it just pop up in your exam. So it would be best that if you can give it a read at least once. And the only thing that you really need to go through is what I have asked you, nothing extra. Okay. And also read that RSCGP guideline, please. Yes, the notes are enough, Dr. Simran. Yeah, so naloxone is for opioid poisoning, and naltrexone is basically if you want to just like gradually wean off the opioid for the patient. Okay, moving on to defense mechanism. Everyone throughout their life in different situations, they use some of the defense mechanism, and most of them are involuntary. That means you or immature. That means you are not even aware that you are using these defense mechanisms. So those are immature, and most of them are immature. And then there are some mature which you use voluntarily. That means by like you know that you're using the defense mechanism to get out of that situation. So there are lots of defense mechanism and a lot of questions come from here. So you need to get a very good idea about this. So I normally go through med bullets for this. All right, so these are also known as ego defenses. Let's have a look. So immature defense mechanism. So first of all, we have got acting out. So acting out means that when a person use action to express something unacceptable. Like let's say that you have been working in an office for years and this was the time you were supposed to get promoted. But suddenly a new guy comes into the office and he was promoted instead of you. So definitely you are angry. Now, to express this unacceptable feeling, you went to your boss office and you started yelling at your boss and started breaking his things. That means you used action to express the unacceptable feelings. So that is what we call as acting out. Okay. Dissociation, we know. Denial. Denial is avoidance of awareness of some painful reality. So suddenly a person came to know that they have cancer. Okay. And then he went to home and wife asked him that you went to the doctor's office today. What did you find? And husband just said that nothing, I'm fine. Now he did not do it purposefully. He just can't remember. So denial is avoidance of awareness of some painful reality. Okay, so when a patient just denies something which is like unimaginable for that patient, that is denial. But remember, it is not purposeful. They actually They can't actually remember because they're in shock at the moment. Okay, so that's denial. Next, displacement. Displacement is taking feelings out on a neutral third party. Let's say that you had a fight with your boyfriend, and then you came home, your father or mother was just waiting for you because they wanted you to have dinner with them. Instead of having the dinner, you started yelling at your parents and said that everything wrong is because of you. So what you did is you had a fight with your boyfriend, but you displaced that anger to someone who has nothing to do with what happened with you. So neutral third party. Okay? So taking feelings out on a neutral third party is what we call as displacement. Fixation is not needed, fantasy not needed, identification. Identification is imitating behavior of a more powerful person. So many times children, they imitate their parents because they think that they are the role model, right? So that is called identification. When someone imitates behavior of a more powerful person in their life, whether it is a good or bad imitation, that is identification. Isolation of affect. Affect means mood, right? So mood or like feelings of a patient. And isolation of affect means separation of emotion from a particular event or ideas. Like your patient who has been charged with murder is describing how he murdered an innocent person in graphic detail without any emotion. So that is separation of emotion from some event. And that is what we call as isolation of affect. So isolation of affect means separation of emotion from some event or ideas. Like if someone is describing murder in every small detail without even showing any emotion in it. So they just separated the emotion out of the thing. Passive aggression. Passive aggression is, remember the acting out, the first thing we discussed? Acting out means you just acted out. You started yelling or fighting. But passive aggression is you are expressing your angry feelings in a non-confrontational way. Which means that let's say you're very much angry with your friend and you actually wanted to punch your friend, but you did not. Rather punching her out, you just stopped texting her, you stopped seeing her, talking to her for the next 1 week. That means you expressed your angry feeling without doing any violent thing. Okay, so that's called passive aggression. Projection, very important for exam. Projection is attributing unacceptable internal feelings to an external source. Now, projection will be like, let's say that you are doing something wrong and you are accusing someone else for your own unacceptable feeling. Like if a husband who is cheating with his wife, he is accusing his wife that you are cheating with me. So philandering husband claims his wife is cheating, but actually he is the one who is cheating. That's called projection. Projection means projecting your unacceptable feeling to someone innocent. Okay? Now remember why it is not displacement. The displacement is the third party. Okay, so the displacement is you will have most of the time it is like the fighting. So you have a fighting with someone, but you are actually displacing the anger to someone else. Okay, you are not actually like doing something wrong. That means like you are not actually cheating with someone and then you are accusing someone for that. Okay, so but displacement is basically like you are angry with something and you're displacing the anger feeling to someone else. Whereas projection is some kind of blame, or you are actually the one who is wrong. So you have done something really bad and you internally or subconsciously, so in your subconscious mind, you can't accept it, but you're still doing it. So your subconscious mind is just projecting that unacceptable feeling to someone who you are actually doing fault, right? So you are actually, like, let's say the patient is actually cheating with the wife, but this unacceptable feeling the husband is having, he is actually projecting that blame to the wife, to the opposite person. Okay, so that is what we call as projection. Okay, so it can get quite confusing in the exam because more or less they are same. Next, rationalization. Making excuses to avoid the real reason for actions, to avoid blame. Let's say in rationalization, patient will have, they will claim, like let's say someone failed in the exam, and to rationalize that failing, patient just mentioned that, well, the exams are not important for life. Okay, so the actions are all that's important. So when someone rationalizes something to avoid self-blaming, that's called rationalization. Okay, so rationalization is making excuses to avoid the real reason, to avoid self-blame. Like someone murdered a patient or someone murdered another person, and then the murderer says that, well, he was a bad man, that's why I just murdered him. That's rationalizing or making excuses. Reaction formation. Very important for exam, when a person replaces an unwanted feeling with exactly its opposite. Like a patient with hypersexual thoughts becomes a nun. Or a more better example would be like a thief who was stealing from everyone suddenly became a priest. So when someone replaces an unwanted feeling with exactly its opposite, someone who was antisocial started to help people in the street. So that's called reaction formation. Okay? Regression. Regression is reversion to more childlike behavior. Like a child who is toilet trained suddenly started bedwetting. That's regression. Repression. Involuntary withholding of bad thoughts from consciousness. So, involuntary withholding of bad thoughts from consciousness. Let's say patient was a victim of rape, okay? And when you asked about the incident, patient can't remember anything that happened. Now, patient actually can't remember, okay? So that is called involuntary withholding of bad thoughts from consciousness. It is actually human brain sometimes stops certain experience just to protect that person, okay? So that is called repression. If someone voluntarily withholds some bad thoughts, that's what we call as suppression. Okay, so suppression is voluntary withholding of some bad thoughts or experience. And when it is involuntary withhold of bad thoughts, that's repression. Splitting. We talked about splitting, that it is a common finding in borderline personality disorder, where a person believes that people are either all good or all bad. Okay, so that's your splitting. So these are the more important ones that comes in exam. So I can understand some of you actually got it wrong about the timing of the class. That's why I mentioned in a couple of places so that you guys don't get it wrong. So it is mentioned in your schedule that from today, because of daylight saving, the time has changed from your country to Australia, because Australia is 1 hour ahead. So if you are in Pakistan, India, Bangladesh, you will find out that the time has just like it is a bit changed. So check your time and then join the class accordingly so that it doesn't happen. Okay. And you can always go through the recorded session if you have missed that initial 1 hour session. I'm not sure, Dr. Deep, what is the BD time? You just need to Google it. So just Google what's the time in Sydney now and what's your time in your country, and then you will find out the difference. Okay. So if it was, let's say, 5 hours before, now it is 6 hours difference, so something like that. And Dr. Praveen, rationalization is making excuses for something that they that that they want to avoid the self-blaming. So if someone says that no, it's not actually because they're successful. So if they say that, well, I drink because drinking is healthy for me, or drinking helps me to sleep, that is rationalization. Example of reaction formation. So let's say someone, so it's like changing a person's unwanted thing to something exactly opposite. Like a patient who was a thief, who used to steal from people, suddenly started to preach. So suddenly became a priest or a religious leader. Okay, so that means he just changed himself to the exact opposite. Now, denial actually, I know it is a bit difficult to differentiate between denial and repression. Denial is, it's a initially. So patient initially, they will they will refuse to believe that they have something bad, like AIDS, cancers, okay? But eventually they will remember everything. Whereas repression is something more worse, and they will not be able to remember that part for a long, long time. Okay, that's repression. So now see this one. Altruism is alleviating guilt through charity and generosity. Like a criminal donates to the church. That's altruism. So a patient with Hep C starts working in a charity organization serving Hep C patients. So it doesn't look like a reaction formation, right? Has he changed himself? Like previously he was a drug addict, now uh, he is like a, let's say a patient, a person who helps people. If something like that, because Hep C doesn't necessarily means he was a drug abuser, right? So the reaction formation is changing someone to exactly the opposite. Okay, so it could be altruism that he is doing now. Intellectualization is like that you will find out a lot of people just try to show that they are very much intellect. They even the let's say like a patient comes to the doctor and he is actually trying to teach you about lots of diagnoses, lots of medical things where you are the doctor. Okay, so that's what we will call as intellectualization. No, it is unconscious. Everything that we discussed in here, these are immature, which means they are not actually doing it consciously. Yeah, they are genuinely changed, Dr. Fajia. They are not pretending, definitely. All right, so that's all that you need to go through for reaction for the defense mechanism. Okay, we'll take a 10-minute break now, and then we'll restart. Now, for that questions like, yes, Dr. Nabil, very good. Altruism needs a guilt. So that question we actually want to know, like if there is any guilt that patient is having. So as the question was asked between reaction formation and altruism, it is not definitely a reaction formation. So it could be altruism if the patient has any kind of guilt behind it. Okay, but otherwise it's nothing. Ten-minute break, guys. Thank you. All right, everyone, let's start again. So we finished up to the ego defenses. Now the dementia and delirium. So delirium and dementia, you need to have a basic knowledge for this too. So in a single word, dementia is a chronic condition, and mainly these patients are forgetful or they have cognitive impairment. Whereas delirium is an acute episode where they become confused just within hours to days. Okay, so dementia is a chronic forgetfulness, and gradually it just gets worse. And delirium is an acute condition, which is mainly patient has like an altered mental status and confusion. To check someone's memory, there is a bedside test that we can do called mini mental status examination, or in short, we use MMSA. So it is the single best indicator of dementia and should always be evaluated by a formal memory testing. So when we do the MMSA, the score is 0 to 30. If someone has got between a score of 19 to 23, that's mild dementia. 10 to 18 is moderate dementia, and less than 10, severe dementia. Okay, so again, I told previously that if someone's MMSE score is less than 10, they don't actually have the mental capacity to give consent for their medical treatment. So when we do the MMSE, we look for these 6 things. You don't need to know how to do this, but just remember these are the six specific things that we look for. One is orientation, second, registration, attention, recall, language, and construction. So we ask lots of questions to the patient, and patient answer those questions, and we give them a score. So in patient who has delirium, their orientation and attention will be significantly impaired. Whereas a patient who has dementia, their registration and recall will be impaired. And both delirium dementia can have impairment of language and construction. All right. So sometimes in the question, they give you a patient who has chronic forgetfulness, getting worse, and they ask you that what would be the finding in your MMSE? And the finding in the MMSE would be impaired registration or impaired recall. Okay. Now, apart from doing the MMSE, there are some other screening tests we can do to check for cognitive impairment in elderly patient. And dementia is common in elderly patient, okay? And one of the tests is known as clock face drawing test. So what are the clinical features of dementia? Most importantly, loss of memory, and they have trouble to remember any new information. They can have difficulty to remember names, personality change, so they might start to become very withdrawn, they don't go outside, and they can also have inability to make decision. Many times, depression and dementia can be together and can be very, very difficult to differentiate. So dementia is forgetfulness that we know, but sometimes if a patient, especially an elderly patient, if they have severe depression, they can also show features of dementia, like they can have forgetfulness. That is not called depression anymore, that's called pseudo-dementia. Okay, so dementia and pseudo-dementia is different. Dementia is the actual forgetfulness or actual memory problem. But pseudo-dementia is patient has like features of dementia like memory problem, but they're actually severely depressed. So how we can differentiate pseudo-dementia from dementia? That's important to know. So this is the table. So dementia is chronic, whereas pseudo-dementia sometimes can be very acute. Dementia, the forgetfulness, memory get worse at the evening or at night, whereas depression or pseudo-dementia get worse in the morning. The most important difference is insight. Patient with dementia, they will not have any insight about their problem. That means they will not actually know what's going on. Whereas pseudo-dementia, they have insight. Dementia patient, they can have poor orientation to time, place, persons. They might not know where they are or who you are, or even they might not remember which year it is, which date it is. Okay, so they will be disoriented. And in pseudo-dementia, they will not have any problem with that. Another important way to differentiate between these two is response to mistake. If a dementia patient do any mistake during the MMSE, they will be very agitated and angry because they want to make high score. Whereas pseudo-dementia, they don't care about any score, so they just give up easily, and they don't become agitated or frustrated if they do any mistake. Okay, so these are the way to differentiate between dementia and pseudo-dementia. So while we are talking about dementia, what are the types of dementia? So as I said, the dementia is common once the patient become older, but the most common cause of dementia is Alzheimer's disease. About 60% of dementia is due to Alzheimer's. Then we have frontotemporal dementia, then Lewy body dementia, and we have vascular dementia. So these are the four common causes of dementia. So Alzheimer's, frontotemporal, Lewy body, and vascular. And there are lots of other causes as well. So how we can differentiate between all of this? In Alzheimer's disease, the main or initial symptom will be forgetfulness or loss of memory. And then eventually, they will have like behavioral problem, they will have social interaction problem, but the main or initial symptom for Alzheimer is forgetfulness. And a lot of time there will be a family history positive. In frontotemporal dementia, their initial symptom is personality change and behavioral change. And then they start to become forgetful. So how it starts makes a lot of difference because frontal part of your brain actually makes your personality and it controls your behavior. So a patient who has frontotemporal dementia, they will mainly present to you with behavioral disturbance. How about Lewy body dementia? Lewy body dementia patient can have Parkinson-like problems. So they can have motor Parkinsonism. So they can have Parkinson-like gait. They can have bradykinesia, tremor. So they will have motor Parkinson. They will have visual hallucination. And they can have forgetfulness as well. So when a patient has at least two of the three, and the two of the three is one is visual hallucination, second is motor Parkinson, and third is forgetfulness. So if anyone has two of these three, you can diagnose that patient as Lewy body dementia. Among all of these dementia, the three we have discussed, all of them are chronic. But if a dementia starts very suddenly, like patient had a head injury and suddenly patient start to get forgetful, that's the time you would think of vascular dementia. So it starts suddenly, and many times it can have neurological problem. And many times there is an underlying stroke or cerebrovascular disease causing this. That's why if an elderly patient comes to you with a very recent onset of dementia, even without a head injury, we do a CT brain just to rule out any chronic subdural hematoma causing this vascular dementia. Okay. So behavioral change can be anything. So patient can just patient went to the market, and in the middle of the crowd, patient can just put off their pants in front of everyone. So patient actually lose their personality. They can start to urinate in the public. Okay. So those are the extreme behavioral change, and all of this can happen in these patients. Okay, the difference is delirium is an acute condition, which is acute confusion, and dementia is basically chronic forgetfulness. A lot of difference between these two. Okay, so this is mainly what you need to know from dementia. So you need to know what is dementia, what are the main symptoms, what are the types of dementia. Okay, and other things you can give it a read, whatever it's written in here, not important. Dementia preventive strategies. Healthy blood pressure is really important to prevent dementia. Physical activities, mentally stimulating activities, social activities, these are all important for dementia prevention. There is a term called paraphrenia. Paraphrenia is also known as late onset schizophrenia. So if a patient develops features of paranoid psychosis for the first time in the elderly patient, so patient never had schizophrenia, and now patient is 70-year-old and suddenly started to have paranoid psychosis. That means they are suspicious, they feel that everyone is trying to murder them. Okay, so that's what we call as paraphrenia. And for that patient, you will need to start antipsychotic medication. So if a patient has place, person, and time lost, they are actually disoriented. And disorientation is a feature of delirium. Any information can be lost, doesn't matter which one comes first. Paraphrenia is someone who just got the psychotic features for the first time when they're elderly. Yes, paraphrenia also needs 6 months. Delirium. Delirium is it has a lot of other names. So we have acute confusion, confusional episode, toxic confusional state, acute brain syndrome. So all of these are same. But the main gist is when a patient suddenly becomes confused and disoriented, that's what we call delirium. So clouding of consciousness, disorientation, impaired attention, and it happens over days and hours. Okay. So delirium is, so you can see that patient, according to the DSM-5, disturbance of consciousness attention, very short period of time this will happen, and they can have disorientation. Even they can have memory problem, but it will be acute memory problem. The speech might not be understandable, and perception disturbance. So these people can also have hallucination. Okay, so how we would say, let's say a 67-year-old patient suddenly came to the hospital brought by ambulance because the patient is confused, can't remember where they are, can't remember any date, place, person, and you can't understand anything patient is saying. That is the time it will be delirium. Okay, so these are also common in elderly patient, and these patients can have like fluctuation of their consciousness. Sometimes this delirium patient can be totally fine, and then suddenly they can go downhill. So their level of consciousness can fluctuate. They can have psychotic symptoms, like they can have hallucination, they can even have delusion. Okay, and it can get worse at night. Always remember, if a patient suddenly presents with delirium, the first thing we want to rule out is if there is any infection. And the most common infection that causes delirium in elderly is UTI. So patient might not have any symptom of UTI except just confusion. Still, you need to make sure that you rule out UTI. So send the patient for a urine microscopy culture and rule that out. So after infection, rule out any medication, especially any anticholinergic drugs. So the tricyclic antidepressant is the anticholinergic. So anything which is anticholinergic sometimes can cause delirium in patients. So if a patient has delirium, what will be the treatment? Because these patients are acutely unwell. So if a patient with delirium has just anxiety and depression, you can give them midazolam to sedate. But if they have psychotic behavior, which is most of the time they will, you'll need to start them with IM haloperidol. They said oral but psychotic patients sometimes, if they're verbally aggressive or they're very much angry, then better will be IM haloperidol. But if patient is not aggressive, you can try oral haloperidol or olanzapine as well. Okay, so if a patient has delirium, only symptom is anxiety, then midazolam. If it is psychotic behavior, then haloperidol, IM is usually the treatment. So we discussed about schizophrenia, so those are all fine. So this is all about delirium and dementia that you really need to know. Any question, guys? That's right. Delirium is sudden and dementia is gradual. Electrolyte imbalance, if there is any indication, if a patient is on any diuretics which can cause hyponatremia, yes, you should check the electrolyte. So dementia, a lot of dementia cannot be treated, okay, because it is a progressive condition, especially frontotemporal dementia, there is nothing you can do. Vascular dementia, you need to treat the underlying cause, which is a stroke most of the time. Then Lewy body dementia, again, it is very difficult to treat. So many times those patients, you can't do much apart from just symptomatic management. Like if we see here, it's very difficult. Demented patients often do not require any psychotic medication. Antidepressant can be prescribed for depression. So if a patient with dementia has depression, you can try them antidepressant. Now, the only thing that sometimes can be used, and that is usually for Alzheimer's, is cholinesterase inhibitors, which is donepezil, galantamine, or rivastigmine. So this is not used for all dementia except Alzheimer dementia. Okay, so these are cholinesterase inhibitors which you can use: donepezil, galantamine, or rivastigmine. Now, alcohol withdrawal is sometimes alcohol withdrawal can present as delirium. So they will not actually ask you to differentiate between these two. Okay. So one of the cause of delirium can be alcohol withdrawal. Diazepam, we normally use midazolam more than diazepam for such case. But if midazolam is not there, then diazepam can be used. In dementia, consciousness is impaired or not. The earliest stage, their consciousness will be fine, and they are not usually violent most of the time. Okay, the consciousness is main problem in delirium, not in dementia. Yes, it is safe, should not be a problem. IV haloperidol is not ideal because someone who is aggressive, they will not allow you to go for, like, they will not allow the IV line to go, like to have the medication going into their vein. They will just rip off the IV line. So IM is the best. Okay. But I believe there will be much better option, Dr. Midhat, than IV. There should be something IM for an aggressive patient in the exam. Okay, moving on to impulse control disorder. For impulse control disorder, we use Kaplan Step to CK, chapter 12. Okay, so there are lots of impulse control disorder, which is not super important for exam, but time to time it can come in the exam. So you just need to know. So one is this intermittent explosive disorder. Intermittent explosive disorder is it is a disorder characterized by discrete episodes of failure to resist aggressive impulses, which causes serious assaultive act or destruction of property. So these kind of patients will have a sudden urge or impulse to do something destructive. And later on, they will feel like guilty or remorseful for that. The degree of aggression is typically out of proportion of the stressor. Like if you look at here, police arrest a 24-year-old man after he beats up an older man, causing severe injury to his head and neck, requiring more than 100 stitches. When asked why he assaulted the older man, he replies, "He took my potato chips." So you can see the stress is very small and the aggression is really out of proportion. Okay, and this attack can occur within minutes to hours, and as long as they don't act on it, it will just make them very anxious. Okay, so that is intermittent explosive disorder. You can go through these things. Treatment, pharmacological treatment can be done. It's like you can give them antipsychotic, anticonvulsant. Psychotherapy is not the preferred treatment, but it can be an adjunctive treatment. So the main treatment for this kind of condition will be pharmacological treatment. So many times you can give them antipsychotics like risperidone, which works really, really good for anger outburst. Okay. Kleptomania, a disorder characterized by recurrent failure to resist impulse to steal objects that the patient doesn't need. So there are patients who steal tiny small objects which even they don't use or need. But this is kind of an impulse that they can't control. So 25-year-old woman has a history of more than 20 arrests for stealing small items. She comes from a wealthy family. Her parents do not understand her behavior. At home, she has numerous salt and pepper shakers, napkin rings, ashtrays, none of which she needs. So that's kleptomania. So for kleptomania, you can send them to a psychologist for insight-oriented therapy or behavioral therapy. What is pyromania? So kleptomania is failure to resist the impulse of stealing. Pyromania is a disorder characterized by deliberate fire setting on more than one occasion. So in these patients, they feel like they have an impulse of deliberately setting fires on someone's house or maybe someone's rubbish bin. So they feel anxious if they don't do it. And after setting fire, they feel gratified. So 19-year-old teen with mild intellectual disability is arrested after he is found setting the neighbor's garbage can on fire. Neighbors had observed him in the past starting fires in his own backyard, staring at them for hours, watching them burn. So these are the patients who feels that they get an urge or impulse to set fire. Okay. Treatment, there is no treatment which is beneficial. Incarceration may be indicated if the patient sets fire to everything. Next, gambling disorder. DSM-5 puts the gambling disorder under substance abuse or addictive disorder. So it's no longer part of impulsive disorder in DSM-5. So gambling disorder, you means that a patient who has persistent, recurrent gambling, and if they don't gamble, they feel anxious and eventually like they have lots of problem. So recurrent gambling behavior that includes preoccupation with gambling, a need to gamble with more money, attempts to stop gambling and then going back again. So the gambling disorder, it is a difficult disorder to treat. But the treatment, according to Australia, is that you can send them to Gamblers Anonymous, where they can talk to people who are also suffering from the same thing. Okay, so it's kind of like a talking to people who is going through the same thing and getting some help. Psychotherapy sometimes can work, but it's not like always. You can always send them to a counselor. Trichotillomania. Again, in DSM-5, trichotillomania is under OCD. So it's a disorder characterized by pulling one's own hair, resulting in hair loss. There is anxiety before the act and release of anxiety after the act. So trichotillomania is a patient who feels that they need to pull their hair. And if they don't pull their hair, they feel anxious. Okay? So pulling, now this is important, that how to differentiate trichotillomania from alopecia. So alopecia means loss of hair. And in alopecia, there will be complete loss of hair in some areas of the skull. But in trichotillomania, because they pull hair, they will not, it will be like a partial broken hair shaft. Okay, so when there is partially broken hair shaft, not complete loss of hair, that's trichotillomania. Okay. And the treatment is mainly sending them to psychologist for some behavioral modification. Yes, Gamblers Anonymous is practiced in Australia. Okay, so that's basically all the impulse control disorder that you need to go through. Moving on to eating disorder. Very, very important for the exam is eating disorder. There is not much in anywhere, not in Kaplan or John Murtagh. There is a chapter for anorexia in John Murtagh, which if you want, you can go through, but mainly we want you to go through these two. So RACGP has a good discussion about eating disorder, and you need to go through that. So eating disorders are very complex. Sometimes it can be life-threatening with significant medical and psychological consequence. And there are lots of eating disorder, but the main thing that you need to know for your exam is anorexia nervosa and bulimia nervosa. So what are these? It's very important to know how to differentiate between these two. So anorexia nervosa, the patient has intense fear of gaining weight. And even though they might be like very low body weight, they feel that they are obese. And because they don't want to gain any weight, they have this persistent behavior which interfere with gain. Again, the patient who has intense fear of weight gain and they do some restrictive behavior. The restrictive behavior can be restriction of energy intake by starvation. They can do a lot of excessive exercise to lose their body weight. And they have a disturbance in their body image. That means they feel they have a low self-esteem, they feel inferior to others, and they feel that they need to lose weight for gaining people's attention or everything. So when a patient has abnormal body image and shape, and to improve their body image, they start doing some restrictive behavior not to gain any weight, self-starvation, excessive exercise, induced vomiting, so anything that lets them to lose weight. And this patient will lose weight significantly and their BMI will be less than 18. You know that normal BMI is between 18 to 24. This patient's BMI will be less than 18 and they will have significant weight loss. So these are the three criteria to diagnose someone as anorexia. So what is bulimia? Yeah, eating disorder is common in female. Bulimia nervosa is, in bulimia, patient has this recurrent episode of binge eating. So sometimes they just eat excessively and then they feel guilty about it and they do some compensatory behavior to prevent the weight gain, such as they can vomit by putting their hand into the mouth. They can start laxatives, diuretics, fasting, excessive exercise, and they do it at least once a week for at least 3 months. Now, how to differentiate between anorexia and bulimia? Anorexia will not have binge eating pattern, whereas bulimia will have a binge eating and then it will be followed by a compensatory behavior. And bulimia nervosa, because they do binge eating, they don't lose weight like anorexia, and their BMI will be more than 18. So BMI is a very important difference between these two. And also the pattern of binge eating is important to diagnose bulimia nervosa. Does it make sense, guys? Good. Now there is another condition which is only binge eating disorder. So binge eating disorder is a patient who suddenly they lose control over their eating and they do the binge eating, but they don't feel like they need to lose weight by doing the compensatory behavior. Okay, so when it is only binge eating, but there is no compensatory behavior or any guilt about weight gain, that's binge eating disorder. Okay. Now, that's very important to know how to differentiate between this. Now, lots of other things comes in exam. These are all the investigations we do in a patient who has eating disorder. So sometimes the question asks that which of the following is not an investigation that we do for eating disorder patient? So you need to remember all of these tests. Management. The first priority is that is the patient stable enough? And does the patient requires admission in the hospital or not? So there are some indication of hospitalizing these patients. So you can go through this indication in your own time. Doesn't really come in exam, but you can go through that. Now, main thing that comes in exam, I will show you from other guideline. Okay, so this is not available anymore. There was a previous guideline which was quite useful, but let's see. Okay, so some of the physical symptoms of anorexia nervosa is important to remember. So remember, a patient who has anorexia, they can have several physical symptoms, such as they will have dry skin, they can have lanugo hair, they can feel very cold or tired all the time. And these patients also can have ankle edema because of malnutrition. So ankle edema, dry skin, lanugo hair, feeling very cold, those are mainly the features of anorexia. And anorexia patient also can have hypotension, tachycardia. Now, for patient who has bulimia nervosa, they will have brittle nails because they sometimes put their hand into the mouth. They can also have sometimes dental caries, parotid gland enlargement. This patient can also have menstrual disturbance, especially anorexia nervosa patient. They can have amenorrhea or irregular period, very common. Okay. So the questions that comes from eating disorder is one, it comes from like they give you a scenario and they ask you the diagnosis. Second, they give you the diagnosis and they ask you what is the most common physical symptoms you can get in this patient. So remember, for bulimia nervosa, dental caries, parotid gland enlargement, then so those are common, whereas for anorexia, malnutrition symptoms are common. And also the treatment. So for both of the eating disorders, psychological counseling is the first line treatment. But there are some specific psychological treatment that we offer. For anorexia nervosa, the CBT or counseling that we offer is called family-based therapy. So you involve the family member and they usually make a plan to help the patient. Bulimia nervosa, the treatment is cognitive behavioral therapy. Okay. Yes, amenorrhea is in anorexia nervosa. not that much in bulimia. And yes, parotid gland enlargement because they put their finger in their mouth, and it can induce more and more like salivary gland enlargement because patient is trying to vomit. It induces more saliva and everything. And many times it causes infection of the parotid gland as well. So that's basically it. So eating disorder is super important for exam. Please make sure you go through the RACGP guideline. And substance abuse we already discussed. From RACGP, you can also read a little bit. Now, the only thing I couldn't finish today is the childhood psychotic disorder. So childhood psychotic disorder, I will try to include in some other classes. Maybe it could be the left out topics, but that we will discuss in some other class. Okay, I need at least half an hour to discuss that, but we don't have that much time today. If a patient has a current suicidal thought, then GP should send the patient to hospital. If the patient doesn't want NG tube, you can arrange a parenteral, like IV nutrition. Dr. Praveen. So rate control is first. If rate control doesn't work, then rhythm control, and then anticoagulation. Yes, so innocent murmur is systolic. All right, everyone. So please finish the psychiatry as much as you can. Go through the EU World psychiatry topics as well. The topics are all that I have discussed, nothing more, nothing less. Okay? If you can do what we have discussed, that's more than enough. Amiodarone is for rhythm control. So if you can't control the AFib by rate control medication, then you can use amiodarone. When to give parents erythromycin? So if there is a less than 6-month-old child at home, then the whole family members will get the antibiotic. No need to go through Kaplan. We discussed the Kaplan in the class anyway. It should be okay. So any of the antiarrhythmic can be used. Amiodarone, flecainide, sotalol, anything can be used. Those are definitely the second line. No, the 6-month-old is already getting the treatment. But if there is another less than 6-month-old, so most of the time, let's say a 4-year-old child has been diagnosed as pertussis, and then there is a 2-month-old child at home. So that's the time the whole family member will be treated. No, if the rate is controlled, then we don't need to give beta blocker. But 90 is still on the higher side. So I would still start the patient with beta blocker in such case. But if it is like 60, 70, then I would not. Immunization booster. So if parents did not have any pertussis for the last 10 years, then you can ask the parents to get a vaccination. If the criteria fulfills, then erythromycin first. We discussed it, Dr. Praveen, in our class. So serotonin syndrome we discussed in detail. Please go through the recorded class. So that was discussed in the first class where we discussed depression, antidepressant, all of them. It is already available, this class PowerPoint, Dr. Patel. So it will be under Psychiatry Class 2. So there is no Psychiatry Part 3 note because Part 2 and Part 3 is together. No need of aspirin for AF. Dr. Faizia, you did the class. Why you are asking these kind of questions where we discussed everything about AF? I remember you were in the class for cardiology. There is no more aspirin for AF. There is either you give anything, so either there is no anticoagulation or warfarin or like the newer anticoagulant. No indication of aspirin anymore. So aspirin was the previous guideline. So I think you might have seen the previous guideline and got confused, right? It's okay. So before the new CHATS VASC score, there was just CHATS, something like CHATS. I can't remember even. So that time we used to give either aspirin or warfarin. But because no longer we give any of this as a first-line treatment, now we use the CHATS VASC score. So according to that score, either you give them anticoagulation or you don't give it. Yeah, no, don't follow everything that's written in the Amidex because Amidex is not updated. So as I said first time that Amidex is written by someone like you or someone like us. It doesn't mean that it is the absolute guideline. The absolute guideline is what is written in a guideline like RACGP, RCH. So that is the absolute guideline. Okay, so please do not get confused by Amidex or any Q bank. Okay, so if we are saying something in the class, mostly those are updated guidelines that we follow in Australia. If something you feel that I am saying wrong, just tell me. I will have a look and I will rectify it because we can always make mistake and that's totally fine. But if something is in the guideline, just follow that. Okay. Clopidogrel is used after you start the, like many times what happens that when a patient gets their, is that main treatment done, like they have a stent put in or they have a CABG done, after that initial treatment, we put the patient on aspirin clopidogrel, but not at first. All right, guys. Thanks, everyone. Have a good night. Take care. No, we should not give clopidogrel before PCI because patient can bleed. You should wait before, first you do the PCI, then start clopidogrel. Thank you. Bye.